Okay, so the first part of this presentation today is just looking at the KV imaging systems and the MV imaging systems that are on the Linacs themselves. So separate to the CT stuff, which I think Peter covered with you 2 weeks ago in your presentation. So we're just looking at the imaging systems that are attached to the linear accelerators. And then Jill will talk about how we use those systems to do image matching in treatments. So just as a bit of a background, and I'm sure you've heard all this before, so it's well known that patients can be difficult to set up. Some of the patients are in pain, they can't lie still for long periods, they're in uncomfortable and awkward positions as well. So we know that the targets that we're trying to treat inside the patient can move position both between fractions, so that's interfraction, and also during fractions, so during the treatment, and that's what we call intrafraction changes. So the tumours and also the patients themselves can change shape and size over the course of treatment as well, whether they're getting swelling from treatment or they're losing weight due to their treatment and their illness as well. So all of these things can affect the quality of the treatment that your patients are receiving. So particularly when we're moving to something like IMRT and VMAT imaging, either before, during, or after, and if possible, all of those is essential to make sure that we're actually treating the target inside our patient. Usually the imaging technique that you use during treatment is dictated by your radiation oncologist, and in some cases it's through guidance by a medical physicist, but the imaging used on our patients is always delivered by the radiation therapist. So that's why it's really important that you all understand how the imaging works and a little bit of the theory behind the imaging processes. So on the linear accelerator, there's KV imaging systems and MV imaging systems. So I'll start with the KV imaging systems. So we use what's called an onboard imaging system, or an OBI. And the really important thing about the OBI, because the KV imaging system is, whilst it's attached to the Linac, it's quite separate to the treatment beam. So the isocenter of the KV unit must match the isocenter of the MV, or our treatment field, exactly. There's no point taking a KV image of a patient and going, yes, they're perfectly positioned, if the beam that you're going to treat them with isn't aligned properly to that KV image. The KV imaging device has arms that you can see coming out of the sides of the linear accelerator, and they rotate around the patient as the gantry rotates around the patient. So one of the arms contains an X-ray tube, and the other arm contains a flat panel KV detector. So it's really important to note, and I only say this because I've done it myself, you cannot rotate the couch while those KV are in the out position, because the couch will hit the KV arms and do a lot of damage. So just be wary of that. So in the OBI system, the KV detector will detect X-rays that are emitted from the X-ray tube. So they won't detect X-rays that are emitted from the gantry head, or part of the treatment beam, because it's going in the opposite direction. And so this KV detector can acquire digital radiographs, it can do fluoroscopy, and it can also do ConeBeam CT projections. So the KV detector and the imaging system itself is similar to what you would see in a digital diagnostic unit. So you can take radiographs with pre-programmed exposures, and you can also do fluoroscopy with automatic brightness control. Some of the differences to your standard diagnostic imaging unit is that the OBI, the KV imager, doesn't have a light field. So you can't see where the KV beam is going to go on your patient, and the OBI isn't capable of automatic exposure control. And Jill, please correct me if I'm wrong in your following presentation. I know Peter talked to you a little bit about ConeBeam CT, but I just want to go over the theory of this a little bit as well, just to make sure that you understand the concept. So a normal CT scanner that you'd have in a diagnostic department or in a radiation therapy department uses a narrow fan beam of radiation that comes from the source and passes through the patient and then hits a very narrow detector. The patient then moves through the CT, so the couch moves through the CT scanner to generate a helical or spiral scan that's then reconstructed into your 3D volumetric image set. On a linac, obviously the treatment couch can't move while the KV beam is on. So instead of using that fan-shaped beam that you get in a standard CT, we use what's called a cone-shaped beam so that you can get a volumetric image set just by having a single gantry rotation. So we don't need to rotate the gantry over and over and over around the patient. A single rotation will give us enough information to create a volumetric image set. So that's the ConeBeam CT. There are two main types of filters that are used in a KV imaging system. So there are foil filters, which are like most filters you'd see in a KV imaging system that modify the spectrum of the X-ray beam and absorb the low energy photons that are useless for our imaging needs. Then we also have the bow tie filters. So what these do is improve the ConeBeam CT image quality. They're also helpful in reducing dose to the skin by, again, absorbing low energy photons. They can reduce the scattered radiation hitting the patient, which creates noise in our image, and they can act like a compensator on the patient. So the filters are mounted on a platform in front of the collimators of the KV imaging unit just after the radiation beam exits the unit itself. So just a little bit more of an explanation about bow tie filters. I know it takes me a while to get my head around this. I'm still trying to come to terms with it. So there are two types of bow tie filters. So there's what's called a full fan bow tie, and we use this when we use a small field scan. So this is when the patient's volume that you're imaging can be entirely covered by the field and the detector. So, a good example of this is a head. And the reason we have the bow tie filter is obviously we don't need that sort of compensator passing through the center of the patient because there's the most amount of tissue there, but we do need some compensation on the edges of the field where the radiation is passing through less tissue. The other type of bow tie filter is called a half fan bow tie. Just looks like a half of the full bow tie. And we use this in a large field scan where only a portion of the volume will be covered by the detector. So things like pelvises that are quite large, you'll only really be imaging half of the image at once. So, and an important thing to note is there is no interlock for the bow tie filter, so it is possible to use the wrong filter or to do a scan with no filter at all. And these are just some examples of what your image looks like with the different filters in place. So in this case, the first image there, we've got a full fan bow tie filter. So that's the filter we should be using. And you can see you get a nice image of the skull there. The second image is the half fan bow tie filter. And you can see you're starting to get some artifact in that image. So you're sort of getting a circular shape appearing in the image. And it looks quite similar to if you have no bow tie filter at all, you'll get that sort of circular artifact running through the image there. And so this is an example of doing a pelvis image. So if we use, and sorry, it's very dark, I couldn't make the image lighter. If we use a half fan bow tie filter, which is the correct filter to be using for the pelvis, we get some nice contrast inside the pelvis itself. If we accidentally use a full fan bow tie filter, you'll get that very dark ring artifact with the lighter ring outside of that in your image. And if you don't use a bow tie filter at all in a pelvis, you'll get a very bright image in the center of the field and then very reduced visibility on the edges of the field. So this is just a quick recap of image quality and KVP. I'm sure you've heard all of this before, but it's always nice to have a refresher. So the KVP in our image detector or our imaging system, relates to the photon energy. And this is the highest peak voltage that's applied to the X-ray tube. So the voltage that's applied to the X-ray tube is what accelerates the electrons from the cathode to the anode, and then they hit the target and generate the photons. So the highest voltage applied really then relates to the highest energy of photon that can be generated out of the unit at that point. So if we use a high energy or a high kVp, the energy of those photons are more likely to pass through the patient. And this is good because it gives less patient dose, and then that means you'll also be getting more photons reaching your kV detector panel on the other side of the patient. And this is really good for thicker parts of the patient, for example, your pelvis, where if you used a lower energy, all of the photons would be absorbed in the patient and you wouldn't get a very good contrast image from that. So if we do use a low energy kVp, because the photons are of a lower energy, they are more likely to be absorbed in the patient. And this can be a benefit if you want good contrast for the images that you're after, and you'll get particularly strong attenuation or absorption in bone and metal using the lower energy kV photons. So this is just an example here of using different photon energies for the same body site. So you can see in the lung case, using the lower energy beam gives you better contrast between the bone and the soft tissue. So the higher the energy, the ratio of photons that is hitting a detector after passing through the patient is not as good as it is over with the lower energy kV beam. So the low energy gives you that better contrast for your bony anatomy particularly. If we then look at the MAS, so the MAS relates to the number of photons that is being generated from your kV unit. So the higher the MAS, so the MAS is the current, so the electron current running through the machine multiplied by the exposure time. So the period, I guess, that the beam is actively exposing the patient, the more photons that are produced. So the higher the MAS, obviously you then have more photons coming out of the unit. So more photons will then be reaching the detector, but this will also result in a higher patient dose because there are more photons. And a lower MAS obviously is the reverse of that. So you'll have less photons and a lower patient dose. And so there's a trade-off between image quality and patient dose when it comes to MAS. So this is just an example of what changing the MAS will do to your image based on a single example. So the image you've got in A is your original, so it's got really nice definition, good contrast between the different parts of the bone. You can see everything really clearly. If we reduce the MAS by half, keeping our kV constant, you'll see that there's actually not enough photons hitting the detector. So there's less photons coming out of the machine, so there's less photons hitting the detector, and we're getting an underexposed image. So that contrast inside the bone is not as good as it was before. If we double the MAS from the original, keeping the kV the same, we'll be doubling really the number of photons that are hitting the patient and thus reaching the detector. And so in the case of C, there are too many photons that are hitting the detector. So this image is overexposed. So there's I guess a bit of an art to finding the right values to get the image quality that you need for your patients. So there's just a Zoom poll. So hopefully Katie is going to. So yeah, this Zoom poll question is about the image that you see there on the slide. So what would you do to improve the quality of this particular image? So whether you would increase the kV, decrease the kV, increase the MAS, or decrease the MAS. And I've never done that.
So we'll let the poll go for another 30 seconds or so.
Okay, so I'm assuming everybody can see those poll results on their screen. So we had roughly half of you said we would increase the MAS of this image, and around about a third thought we could increase the kV, and then 14% wanted to decrease the MAS. Okay, and nobody said decrease the KV. Okay, so in this particular case, the correct answer would be to increase the MAS. So half of you got that right. Well done. So in this example, this was the image that we showed. So this was an image that had an exposure with 2 MAS. So it was underexposed. So if you remember those images we saw previously where everything was kind of white, that was the underexposed image. So if we increase the MAS to 6, you can see we have a much nicer exposure with some good contrast in there. And then if we increase it even further to 24, we've now got the case of overexposure, so that the film is too dark to see. So well done to the 50% who got that one right. So how do the KV and the MAS affect image quality? So we've just got a couple of examples. I'll just quickly run through from Varian TrueBeam Accelerator. So we've got some acquisition parameters over here. So we've got a 70 KV energy and a 5 MAS value there. So in this case, again, we've got a really kind of white image where we can't see a lot of contrast. So we've got an underexposed image here. So there are a couple of reasons for the low exposure. So the MAS is too low. So we've underexposed that image. So we're not creating enough X-rays to reach the detector. And also this image to me looks like a pelvis. So it could also be that the KV value is too low. This looks like a very thick part of the patient. So we probably need a higher KV value in order to penetrate right through the patient in this instance. So an image can present with low exposure in particular area or across the image as a whole. So as I've said before, the MA or MAS needs to be increased so that there are more X-rays passing through the patient, and the KV also needs to be increased when there's an increase in electron density. So when you've got a thicker patient, basically, so a breast tangent, you're only passing through a very small bit of tissue, so that will require a lower KV than a pelvis. So here's another quick example from a TrueBeam. So this image is overexposed, so you can see it's quite dark. The bones in that image are not very clear. So the causes of overexposure are the opposite of low exposure. So in this example, we were using a KV of 140, and so that KV is too high in this situation because we're passing through the neck and the head, which are quite thin areas of the body. So if we then reduce that KV to a value of 70, you can see we've got a much better exposure. You can see all of the bones, you can see soft tissue information. So that's made a huge difference in this image. So moving on from the KV imaging component of the LINAC, we'll just take a quick look at the MV component. I'm conscious of time and letting Jill. So we've got our MV radiation source or virtual source at the top of our linear accelerator, and then we've got our MV image detector panel, which we call an EPID, sitting underneath that. So the MV portal imaging uses the treatment energy to form the image. So for example, you might use a 6 MV beam to create your images. Some clinics will use higher photon energies, like a 15, but sometimes the higher photon energies don't give very good images. So some clinics may choose not to use those. So what it uses is an EPID. So that stands for electronic portal imaging device. So that's that flat panel that you see that your photons hit to create the image. You can also, I guess, use your digital or conventional film cassettes if your linear accelerator doesn't have the EPID attachment on it. So using portal imaging as opposed to your KV imaging may give more dose to your patient just because you're using the higher energies to get those images. But MV imaging is really useful for checking the treatment field shape, particularly if you're using unusual field shapes, conformal field. It's useful for patients who are very thick or wide, where you can't get your KV image up to a high enough KV to penetrate the patient acceptably. And also when there's no possibility of collision with the patient. you could use an MV-KV pair to get even more information about patient positioning. There's two ways to use your MV portal imaging. The most common is double exposure. So particularly if you're using MLCs and very conformal fields, you'll do one exposure with the MLCs or the blocks in your conformal field, and then the second field with a larger open field. So you can then see the position of your conformal field relative to the rest of the patient anatomy. So it's a good way to document where the treatment field is sitting on the patient. So you can also do portal imaging just as a single exposure, and this is ideal for very large fields, like you might be treating an extremity. So you can see all of the patient anatomy within that field having a single exposure. So that obviously gives less dose to the patient as well. So comparing for MV imaging our EPID, which is our electronic panel detector, compared to traditional film. Obviously the EPID can give you an immediate result, whereas film, you have to take the cassette to be processed, either digitally or through your film processing. The EPID is sensitive to dose rate, whereas film is sensitive to the total cumulative dose. EPID, you could use specific number of monitor units for each particular patient, whereas film, you have to think more about how thick your patient may be, and you may have to change settings based on that. EPID, because it's digital, you can get digital image enhancement, and film, obviously, if you're using a traditional film system, you aren't able to enhance that image quality once the film's been taken. And EPID, like film, you can get a hard copy of those images if they're needed for patient records. So I just want to quickly run over the advantages and disadvantages of each of these imaging techniques. So when we use our imaging portal images with our MV beam, obviously this is an advantage for thicker patients where we need the higher energy. It's really good for visualization of prostheses to confirm the gaps between the prosthetic and the patient. It's really useful in field verification. A KV image can't tell you where the field will be because it's a different orientation. So MV images are really great in general for monitoring treatment, and they're really helpful in dosimetry and quality assurance as well. So the disadvantages of your portal images are obviously you get low contrast because you've got higher photon energies. There's more dose to the patient and you only get a 2D image set. With your standard KV technique, you do get better contrast between soft tissue and bone that we saw earlier. There's less dose to the patient and you don't get artifacts as much as you would from prosthetics. A disadvantage again is it's just a 2D image set. The ConeBeam CT, using the KV imager, you get that nice high contrast that you'd see with your standard KV image. You can get really high spatial resolution, so you can see things more clearly. And it's obviously easier to compare a ConeBeam CT with your planning CT. So you're comparing the same imaging technique to the planning set that you had. Obviously, there's disadvantages in that you'll get artifacts from metal objects and there's more dose to the patient compared to a single KV image. And just when we're talking about doses, this is just some examples of the doses that your patients may receive from the different imaging types. So if we're using film, so your standard film with an MV imaging system, you're getting about 50 to 100 milligrade per fraction for your portal image. So by using the EPID, you can reduce that dose by a factor of about 5 by having that electronic system there. So with KV images, a single image is 0.25 to 2 milligray, and an ISO pair, which is a KV pair acquired daily, you'll get 30 milligray in 30 fractions, which is the same dose as one film or portal image of the patient. So by using KV, you can do 30 fractions worth of images for the equivalent of one EPID image. One more Zoom poll, just quickly, sorry. Sorry, Jill. So which imaging technique would be best for visualization of the carina in order of best to worst? So if you could choose any of those systems, which one would you choose first? And then second, then third? Yes.
30 seconds.
Okay, so there's a fair spread of responses here. Around about half of you chose option D, which was ConeBeam CT, then KV, then MV, and about 30% thought KV, then ConeBeam CT, then MV would be the best for visualizing the carina. So let's quickly have a look at the right answer. Okay, so it was option D. Again, about half of you. Well done. So CT is the imaging modality of choice for imaging the trachea and bronchus. And then obviously KV in itself is really good in general, and the MV doesn't provide good contrast because you've got such thin tissue and a lot of air around it. It's really hard to see in an MV image. So that's the end of my section. So feel free to email me if you've got any questions that could pop into your head after this presentation, and I'll certainly answer them as best as I can. But I will stop now and let Jill take the lead.
Sounds good. And I promise I don't have any quizzes for you guys. All right. So just in the interest of time, I'm going to get this going really quickly here. So my portion of the presentation is to talk about what we do with all those great images that you've acquired using some of the skills that Claire talked about. So today we're going to focus on image matching, imaging protocols, and there's a couple videos at the end of my presentation that we'll run through really quickly. This is all related to planar imaging, so only your 2D image matching, and I believe that CBCT will be covered within a later presentation. So Claire mentioned very briefly how, we used to use a lot of port films. So these were hard films that you would take a film cassette, place them under the patient, take your exposure, take it to the dark room, develop it, and you'd have to do the comparison on those images. They were 2D only, and it was truly just a measurement of bony anatomy in relation to where the field borders were. So for the most part, these were done with double exposures, which you can see on image B in this slide. And we always used a physical or digital graticule, and patient shifts were really very manual, and we had to re-image to make sure that we had moved the correct direction and the correct amount. Today, with the advent of digital images, we have so much more freedom to be able to take planar images. So those are our 2D images, whether they are MV or KV. We can take our volumetric images like CBCT. And we can even, in a lot of cases, take video or cine images. So this is an ability for us to take imaging while the patient is in motion. So this is very, very helpful when we're looking at tumor volume that is moving during breathing. And we want to make sure that that tumor volume isn't moving outside of our beam. We can acquire information on the position or movement of the target within the same session or between sessions. So we can kind of do some target tracking. And these digital images all provide sort of real-time information to correct patient position and optimize our target location. One of the things that we really want to do is minimize geographic misses. So if the patient is moving, if things are shrinking, things like that, this gives us a real-time ability to do that. Each software system has analysis tools that aid in the visualization and assessment of patient and target location, and this provides necessary feedback into clinical decision-making. These imaging capabilities allow for extended quality assurance activities, and this can lead to the verification for increasingly complex treatments. So when you're thinking about things like stereotactic, IMRT, VMAT, as these treatments become more and more complex, we have different quality assurance needs. We're able to minimize treatment position errors and evaluate target coverage, thereby mitigating the risk of a geographic miss. And electronic image archiving is also imperative to record keeping for a number of reasons. Often there are legal requirements to maintain patient records, including treatment images for a given period of time. And these archives are also relevant if a patient returns for further treatment or attends another clinic for treatment. Another benefit of digital imaging is the ability of physicians to remotely review and approve or request changes to the patient position. This can be done in a lot of cases with the patient still on the table, or after the fact, the physician can review them offline. So I know Claire kind of showed this image before. We can see in this photo the MV image source, which is the treatment beam, and the MV detector, which is usually referred to as the EFID panel. And those are really the MV beam line. At 90 degrees from the MV axis, we see our KV source and our KV detector. And these arms are retractable. So if we're in a situation where we need to image and then shift the table or something like that, we can retract these arms back into the machine to give us that ability. So today we're going to cover when to use MV and KV versus CBCT, and then the image matching for CBCT is really going to be covered at a later date. So first off, for MV images, these are used to verify treatment fields and for record keeping purposes. These images are not of diagnostic quality, but depending on the body region, MV images can be used to effectively assess the patient position. And generally, we use bony landmarks or fiducial markers as a surrogate for target position. So in a lot of cases, we can't see the target. We assume that the target is kind of in the same spot in relation to bony anatomy that doesn't move a whole lot, or we can implant fiducial markers. In a lot of cases, that's a really, really great way to ensure that you're treating the right area. MV imaging is also useful for quick pre-treatment or during treatment checks. So if you're not sure if the patient's set up appropriately or you think that things are kind of shifting around, it's easy enough to snap a quick pre-treatment or during treatment MV image and assess the positioning. And they're very necessary for quality assurance purposes. In order to assess patient position in 3 dimensions, so not just, soup, inf, left, right, we do need to take a pair of images separated by 90 degrees. And this is often called a stereoscopic or iso pair. Planar KV imaging provides for better contrast and some visualization of soft tissue. It can be used to effectively verify patient and target position, but KV images do not allow you to take an image of the actual treatment field and can be used for position or target verification only. Just like with our MV images, in order to assess patient position in 3 dimensions, a pair of images separated by 90 degrees called a stereoscopic or iso pair must be taken. And then finally, for CBCT, again, just going to cover this at a high level. KV CBCT images allow for bone and soft tissue visualization, which allow users to verify patient position in 3 dimensions. It's an effective tool to verify size and position of target volumes and organs at risk. And it's also very important to note that there are linear accelerators out there that have MV CBCT. So that's using the treatment beam to do one of those CBCT images. And the contrast is a little different than your KV CBCT, but it's still a great tool for image matching. So for our image verification protocols, we need to perform QA daily to validate the alignment of the imaging equipment and the table. Claire mentioned that it's super important to make sure that the KV imager has the same ISO center as your MV beam. So we need to do the same quality assurance on that daily basis to verify that it's all aligned. Additional QA and calibration can be performed by physics or machine technicians on a regular basis as well. So sometimes this is done weekly or monthly to make sure that the table is shifting appropriately and everything is lining up. And these procedures often require specific phantoms. I've put in a picture here of a pentaguide phantom, which is pretty common. And guidelines are generally directed by medical physics. Each clinic can develop their own protocols for when and how images are acquired and govern shift tolerances. So when we're looking at these imaging protocols, we need to have a number of questions that we consider when developing these. The first question is, how often should we be taking images? And this can vary from anatomical site to, how often the doctor wants to see this imaging. The doctor can determine that imaging frequency and indicate it within the treatment prescription. There may be protocols that are informed by clinical trials requirements and larger governing bodies like the RTOG. Daily image guidance can also be indicated in regions where there is greater anatomic variability or a great deal of setup variability. So if you have a patient or an area of the body that has a lot of loose moving skin, like maybe the abs, we might want to do daily imaging there to make sure that our skin marks are lining up to what we're seeing inside the body. And we might want to do daily imaging where there is adjacent critical structures such as the optic chiasm, spinal cord, and other things of that nature. Even with imaging guidelines, therapists may choose to image for a number of reasons, including to verify a difficult setup or if marks have washed off. So if a therapist is working on the treatment machine and sees something or gets kind of a feeling that things aren't setting up as they should be, it's really great to be able to take a quick image and make sure that everything is lined up appropriately. It's also necessary to define what happens at certain shift threshold levels. So when we take an image, what is our tolerance for shifting? Because we certainly don't want to go ahead and move a patient, 5 centimeters or something like that. If that's not within our shift protocol, we might want to look at if other things are in play. So leading into that, when do we require an image to be repeated, pre-treatment or prior to the next fraction? So if we're taking large shifts with a patient or things aren't setting up appropriately, when should we be re-imaging, and when should we consult a physicist or physician really? So if our shifts are large, if things don't look like they're the same size or the same shape, when do we consult a physicist or physician? We have an example here of a shift tolerance policy, and this is just an example, and it's based on plan type. So 3D conformal plans typically have a little bit broader tolerances than we would see with an IMRT or VMAT. And each line shows the magnitude of the calculated shift and the expectations for the treatment therapist. So if I'm a treatment therapist on the treatment machine and I'm doing a 3D conformal plan, there's going to be a threshold where, you know, in this case, it's 2 millimeters, I'm not going to shift my patient. Whereas for IMRT or VMAT plans, anything under 1 millimeter is not going to shift the patient. So you can see our tolerances are a lot tighter. And then we have a tolerance for when we're going to apply the shift and treat. And we have a tolerance for applying the shift, treating, and then re-imaging. And then when we're going to consult with the medical physicist. When there are large shifts or significant changes to the patient anatomy or target volume, we should always be consulting with a medical physicist or a physician. So if we're looking at our imaging and seeing that something's really out of sorts, it never hurts to call the physicist or the physician down to check out the imaging and make sure that everything is as it should be. In some cases, it may indicate a resimulation. So really what we want to get into is the image matching part of this. We've taken all these images, we have all of our protocols developed, and what do we do with them now? Image matching is really the comparison of an image taken on the treatment machine with imaging from treatment planning. So we have our patient on the couch, we have our treatment plan. How do we match those up to make sure that where we are is where we should be? Within all of the imaging platforms, I'm going to try not to get too specific here. There are both automated and manual tools to perform image matching. So the computer can do some of the work for us and then we can tweak it, or we can do all of that image matching on our own. Each software system also has a set of measurement and visualization tools to aid you in calculating shifts and how we can apply those to the patient to position them appropriately. And if shifts are required to move the patient into the planned treatment position, those shifts can be applied automatically in a lot of cases. So we can move the couch from outside the treatment room, or manually, meaning that we must enter the room and shift the patient into the appropriate position from the bedside. In 2D imaging, each image is a planar view. So we're not getting like a CT style volumetric view of the patient. But in order to make our adjustments in 3 dimensions, we use an orthogonal or stereoscopic pair. These are images taken at 90 degrees from one another. And typically, not always, but typically we see a lateral in an AP or a PA. 2D imaging can use a number of techniques. You can have a KV pair where you're taking a KV image, rotating the gantry 90 degrees, taking another KV KV image. We can also take an MV pair, either if, you know, as Claire mentioned, the patient size and shape lends itself better to MV imaging, or if the machine itself doesn't have maybe KV imaging available, we can use an MV pair, and you're taking the imaging then with a treatment beam. And another alternative is to do one MV image and one KV image. So we can take our image with our treatment beam and a KV image 90 degrees away. And this allows us to create a stereoscopic pair for image matching without rotating the gantry. So in 2D imaging, we generally use our bony landmarks to identify positioning variations, but sometimes the patient might have fiducial markers, which are also visible on 2D images. And it'll be evident when we're looking at the visualization age, which one you use. You know, it's really up to you. You have your own approach for using the tools and measurements and things like that. So, you know, everybody kind of does things their own way when they're looking at 2D imaging. Another factor in how we make our patients shift is once we've imaged the patient, what directions can we shift them in and how do we know how to shift them? So in a lot of cases, we have what's called a 6D robotic couch or a 6 DOF, degrees of freedom couch. And this allows table movements in 6 directions. So not only are we doing our translational shifts, so soup, inf, ant, post, left, right, but we're able to do rotations for the patient. Without a fixed off couch, there are some software applications that allow you to translate rotational shifts into planar shifts. There's some software algorithms that can look at a roll or a pitch or a yaw and decide what that looks like in terms of a 2D shift. But this is always a best fit, and the shift should be evaluated following the translation to make sure that what we've done by translating those shifts matches what our planned treatment position is. Anytime we're imaging a patient, whether we have a robotic couch or not, it's important to have awareness of what you can and cannot see in images and apply shifts only in the directions that you can visualize. With a single 2D image, we can't apply rotational shifts. We can only apply shifts in 2 directions. For an AP image, we can only see our longitudinal, lateral, and yaw shifts, but not vertical, roll, or pitch shifts. So in these cases, we can only apply certain shifts there. Where in a lateral, we can see longitudinal, vertical, and pitch, but not lateral, yaw, or roll. In a 3D ISO pair, we might not accurately see the roll. So when we're looking at our shifting, we should always have a policy for the tolerance of degrees of correction when we're looking at a 60 fixed-off couch. And some clinics might have, either a 3-degree or 2-degree allowance. In some cases, this is really patient dependent, because when you're rotating a patient or rolling a patient 2 or 3 degrees, it can feel like a very large roll and they may feel off balance. So sometimes we want to go into the room to make sure that we're shifting the patient and they're not getting a little bit frightened by that movement. The robotic couch, it does help us to align the patient using table movements. It reduces the need for us to physically reposition the patient, so go in and set them up again using their marks. But some corrections do require us to go in and reposition the patient. So sometimes our imaging, despite our best efforts, shows us that we really do need to go in and set that patient up again and re-image. With our ISO pairs, we do need to confirm shifts by repeating images on some occasions after they're applied. So we do a big shift, or we're not sure of those shifts. We need to go sometimes back in and take another image to ensure that we've accurately estimated rotational shifts and shifted those patients appropriately prior to. Another note, again, not going to cover CBCT in great detail here, but ConeBeam CT, we can apply shifts in all 6 directions, but we need to pay attention to the magnitude of the shifts in both planar and rotational directions and re-image where necessary. So looking at those shift protocols and things like that, it's very important to be mindful of those thresholds, but it's also important to be mindful of your degree of comfort with how the patient's being shifted and how they are positioned. If there's something that says that you should re-image the patient and maybe look at your shifts again, the great thing about using these electronic images is that it can be quite quick to do that, and it's easy to program them back into a treatment session to get those images. So I'm going to jump right into some demonstrations of image matching. I don't think we're going to get through all of these, so I'm going to focus on a couple in particular. And we have been very fortunate that we have some clinical partners that have given us some image matching videos to show us how they do it in their clinics. So this one I'm going to grab because it is someone who is a participant in this course who grabbed us a video of how they do image matching with a pelvis, and this is an MV image matching video. Let me get there. I'm just going to reshare in just a second here. All right. So I'm going to skip forward to where the good stuff happens at about 2 minutes here. So one thing to note here is this is an Elekta linear accelerator using Mosaic for image matching and imaging. So what they're doing here is they're taking MV images, and this is one of the visualization techniques. So we have the red being the treatment image and the black and white behind being the DRR from the treatment planning. It is kind of an interesting way to visualize. You can see that the color fades in and out based on what is well matched and what is maybe not as well matched. But one of the things that Elekta does really well is that it allows users to contour. I don't know if you can see the lines that have been drawn along the sacrum, along the symphysis pubis, and along the pelvic brim. So in a lot of cases, that's what we're going to match to. We're going to draw field borders. We're going to draw contours of interest. So in the pelvis here, we see those bony landmarks very nicely. In maybe a breast case, we're going to draw the chest wall or something like that. We also identify the graticule, and a lot of this work is done up front. And when we overlay the images, the lines on our treatment image, we're able to align the border and perform the image match using those lines that we've drawn. So that's a really effective way of using our MV beam to ensure that we're aligned appropriately with the bony anatomy of the patient. As you can see, there's not a whole lot of soft tissue that we can see. So if this is a prostate patient or a cervical patient, we're not seeing true tumor volume here. We're using that bony anatomy. As we're looking at that, there's a lot of different tools that we can use to change the contrast, be able to visualize different things as we're making those contours, but it's a really great tool to be able to position your patient properly. Once they've performed their shifts, we can see that they're getting some shifts here in the sup inf, left, right, and ant post direction. And that's because we've used an orthogonal pair. So we had an AP or PA, and we've had a lateral film, so we can get shifts in 3 dimensions. And now the user can either apply these shifts from outside of the room, or they can go ahead and go into the room to shift the patient and re-image if necessary. So another one, I know we're running out of time here, so I'm gonna go quickly through what a double exposure looks like and how we are going to use that information to appropriately position our patient and make sure that we're in the right spot for what we need to do. So this is on a variant linear accelerator using the OBI or onboard imaging system. And this is a breast and superclav patient using MV image matching again. So on the left-hand side, we have our DRR. So this is our imaging from planning, and you can see the green digital graticule and the kind of light blue or turquoise field outline with MLC leads. And when we take our MV image on the right-hand side, it's going to superimpose, or we're going to be able to take a look at where that field border is in relation to the bony anatomy from a digital perspective. In many cases, our imaging is pre-programmed as part of the treatment calendar, but we can also do this on the fly. And as Claire alluded to, it's important that we're configuring our energy. In this case, they're using a 6 MB low dose exposure and imaging technique. So this can all be done in an automated fashion. Sometimes we might want to tweak this. So what we do is we snap an image of a larger field. And why this is important is within this small field, a lot of this anatomy is movable, right? So we're looking at the clavicle. The clavicle can move based on arm position and shoulder position of the patient. We have the apex of the lung and the rib cage there, but that's all stuff that's in motion as the patient breathes. And really what we want to see is the relationship between this field border and stable anatomy. So we want to assess things like the vertebral bodies. In some cases, we're looking at the jaw, making sure that the jaw is out of the field. So we're looking to see what's in the field is what we want in the field there, is what we want out of the field. And the only way to see that is to image big. So we take a really, really big image of the patient. You can see it on the bottom right-hand corner of the screen. And then we close in the treatment leads to make sure that the patient is where they should be and we're not over or under treating areas that we shouldn't be. Once we've acquired these images, we can evaluate the patient position related to the plan position. Excuse me. And now the user is using some of those visualization tools. So that little slider bar across the bottom is fading in and out the treatment image in comparison to the DRR. So you can see now we're all showing DRR. Rewind a little bit here, and they go back and forth between the DRR and the portal image. So it's a way to visualize and make sure that the bony anatomy is lining up. Prior to that, they were used, I always called it a hot lamp. I don't know if that's the appropriate name for it, but you can see we're looking in the larger area of the image at the DRR. And then it just kind of shows like a little thumbnail of the treatment image. So you'd run it over and make sure that your bone and soft tissue interfaces are lining up and smooth, that it makes sense visually to you. And again, making sure that you're using appropriate anatomy for that assessment, making sure that you're looking at things that don't move, or if they do move, you're kind of taking that with a grain of salt. And when we're looking at this, we make our moves and we assess it in 3 dimensions. So any moves that we make on our AP, we want to make sure that they're not translating to maybe an inappropriate shift for a lateral or tangent pair. So now they're going to go ahead and they will take another image. And in this case, we're doing a tangent image here. So again, left-hand side is our DRR. Right-hand side is going to show where we take our treatment image. And again, we're doing a 6 MB low dose exposure. Just takes a minute to come up here. So we've taken our treatment field image, and we can see very well, we can see the chest wall, we can see the diaphragm, and in this case, it looks like the patient maybe has a tissue expander. And then they can take a larger image. So we're opening up the field to show more of the patient's anatomy. And on the left-hand side, we have now our ability to assess that patient position. So they're using some filters here to show us that we can do different visualization techniques automatically, shifting back and forth again between that DRR and port film, using that hot lamp. So I think this is a really great way to look at your chest wall. So you can see that they move that along and make sure everything is lining up. When you're using these hot lamps or these sort of checkerboard assessment things, you can see as you run the edge along a soft tissue bone interface, if you're not lined up appropriately, there'll be a mismatch between, the DRR chest wall and the MV image chest wall. It will be very evident that you're not lined up appropriately. So once we have our images, they can use whatever makes sense, make a couple little shifts there. So they're checking again. And if it makes sense to them, they can go ahead and save those shifts out, which is what they're doing now. And the computer program is going to give them shifts in 3 directions. So the important thing to note there is that once they have their shifts and they've done what they need to do, they're going to get numerical values out for what they have to do. And then they're going to refer back to that imaging protocol, decide whether they're going to stay outside the room to apply those shifts, go inside the room to apply those shifts, call a doctor, reposition a patient, re-image, all that good stuff. Pretty much the same methods for your KV orthogonal pairs. And I know we're over time. I don't know if anybody wants to pipe up and tell me to quit now or if I can still go. Not sure if anybody has any feedback, but I'll just keep going until someone says stop. So our KV orthogonal pair is the same method. In this case, it is a pelvis patient. So we're going to take 2 KV images. One is an AP, one is a lateral. And in this case, our presets are done for us. So Claire mentioned being able to tweak and set up your KV and MAs. The software systems typically have built-in presets. So you'll say, okay, this is a pelvis patient, this is a chest patient, this is a head patient. In a lot of cases, you'll take an image, it'll look good. In some cases, depending on patient anatomy, patient habitus, you will have to make adjustments to these KV and MAs. So it's not out of the question that you will still have to make those adjustments. The software programs do a pretty good job of estimating what they should be, but one size is not one fits all for for a lot of our patients. In this video, we're using planar imaging again. We're still going to use bony landmarks to serve as surrogates for our target position because we don't really have a ton of soft tissue visualization here. You can see maybe what looks like some fiducial markers there. So if that's something that you have direction from your physician, excuse me, or physicist to match on, you can use fiducial to do those image matches as well. So again, just showing some of the tools that the various applications have to enhance contrast, and it's up to the user how they want to visualize, how they want to make these image matches. But this is a great tool to be able to make little shifts. You can see there, they're just kind of working through. I don't know if we go back, you can kind of see where that line is jagged. And so they're going to make a little shift to move their KV image line back to the planning line right there. So now it should match up. Everything should be pretty smooth, but you see they made a shift on the right and then they made a shift on the left. And so they have to go back and re-verify everything. So that's looking pretty good on their AP. They'll do the same procedure on the lateral. So they use that hot lamp type of feature and make sure that, oh, look, my bony anatomy isn't lining up. my sacrum isn't lining up. There's different colors that you can use. So there's so many tools, and it's just figuring out what works for you in different anatomical regions. I know a lot of people like these different color washes. I really like the hot lamp tool as well, just because I find that it gives me really good ability to see those interfaces for your bony anatomy and soft tissue. So they're using a lot of those tools here. They will go ahead and they will perform their shifts. Here's another tool, very similar to the hot lamp. And they kind of sweep it around. So just in the interest of time, I'm going to cut that one off where we are right now. So that they can do the same thing, focusing on their anatomical landmarks like their symphysis pubis, iliac wing, sacrum, make sure that everything lines up and create some shifts from that. And based on their imaging protocol, shift the patient to the appropriate position. And the last thing I will touch on right now is our imaging, or sorry, our treatment field. So our treatment field, it's often preferable to take our KV images to validate patient setup, but often we require, for record keeping purposes, to take portal images. And these are images of the actual treatment field with MLC in place. And they're important for a number of reasons, including but not limited to validating skin gaps for field junctions. So if we have a patient that has two abutting fields, we need to verify that we are in the right location and not overlapping fields, unless that's what's prescribed. And recreating our treatment fields for a patient return if they come back for treatment to our facility or to another facility for treatment. So I'm not going to touch on KV. We've done our MV double exposure, but I'm going to touch on what we might be looking at for the KV or the MV field verification. So we can see in this MV field verification, it's really difficult for us to detect and assess discrepancies in field placement when we're viewing the treatment field only. Like the treatment field would encompass, part of the iliac crest, maybe a bit of the greater trochanter, not a lot of information here. And because it looks like it's probably a bit of an oblique angle, I think the gantry is at 27 degrees in this case, based on our little picture down here, it can be very difficult for us to see if we're in the right spot. So this is a perfect case for us to identify as a candidate for an open field, so seeing more of the patient anatomy, and then our MLC field. So what they've done is they've taken, and you can see here, I can't see if I'm in the right spot. I mean, I think I am kind of in the, the general area, but I need more information to be able to assess where my treatment field is. So I've taken my field image, and the little MLC leads are very evident there. They also put on a digital MLC, which can be helpful as well. And then we go ahead and we open up those leads, open up the field size to just get more imaging information in there. And again, we can make those adjustments to contrast and all that good stuff to see where we should be. It's pretty difficult to look at an oblique field and make shifts. This might just be for record keeping purposes, but still a very important way to ensure that your patient is, kind of in close to the right region. And typically, at least in Canada, this is what we see a lot of our physicians reviewing. Our physicians want to look at a treatment field. They don't necessarily need to look at our KV imaging. They look at ConeBeam CT imaging in a lot of cases just to make sure, but this is really the nuts and bolts of what they're reviewing, signing off on, and what goes into the patient chart for record keeping purposes. It's also what we would potentially send off to another facility that is going to be treating our patient in the future, and just a great tool to identify where the treatment field is on the patient. So I have run way over my time, so I am going to go ahead and wrap it up there. I think the PowerPoint slides are going to be accessible to you. So if you want to view more of these videos, they are in the PowerPoint slides. When you click on the image itself, it'll take you to a Google Drive location, and you can watch the videos. I don't believe they're narrated, but it gives you a good idea of what they're doing. So I kind of focused on breast and pelvis cases and really only KV and MV planar imaging. But I know in future sessions, there's going to be image matching in more detail for head and neck, thorax, and then touching on ConeBeam CT as well. So I do want to acknowledge the kind folks who have given us some information, including the videos that you saw today and the videos that are included within the PowerPoint slides. And someone from this presentation, from this course, sent us a video yesterday and we got it added in. So that was really cool to see. As Katie mentioned at the beginning, I work for Varian, so I don't have a ton of clinical cases that I can take videos of. So I do appreciate the team members who have gone ahead and created these videos so that we can share them with you. So if there's any questions, you're more than welcome to email me at my email address or ask them now. I'm happy to answer.
In the meantime, while we wait for any questions, were there any other comments, Claire or Ben, that you wanted to emphasize relating to the couple of questions that were posted on MV imaging, meaning more dosing to patients, or the other question was double exposure on MV portal imaging on a...
Look, I think they're really good questions. I think Ben kind of summarized it nicely. Look, whilst the doses are higher for some of these imaging modalities, I think when you've seen what Jill just presented and the importance of why we're taking the images and the fact that these doses are, when you put them in perspective of the total radiation dose that the patient's getting, this is not something that we necessarily need to be worried about, but it's just something to be mindful of, in that you aren't taking unnecessary images, but in most cases these images are entirely necessary. So it's just making sure that it's put into perspective.
If I could just comment as well, and my experience is from Canada, so it might not be applicable everywhere, but in a lot of cases, when we had planned imaging for patients, many of the software programs have the ability to accumulate that dose. So you're able to identify how much dose the patient is getting from imaging. In some cases, it's not necessary, as Ben mentioned, to subtract it from the total dose. In some cases, they do choose to, or they just choose to keep track of it. But being mindful, using the ALARA principle, not imaging for the sake of imaging, but really imaging as per protocol and as per, you know, your professional scope of practice, making sure that you can look at a patient and say, something about this isn't right. I need to re-image. There's absolutely nothing wrong with that, because the risk from a geographic miss or the risk from treating a critical structure like the optic chiasm or over treating a spinal cord is far higher than the risk from the additional dose from imaging.
Fantastic. And it looks like there's one question for ConeBeam CT imaging. What is the highest amount of imaging you can undertake to be accurate before treatment daily?
So in my clinical experience, depending on the anatomical site, a lot of times we do imaging daily. So for prostate patients, when I was in the clinic, we would image daily. The idea is to take as little as possible, right? So in a lot of cases, we can take a half ConeBeam CT. I know Varian has introduced a lot of new imaging techniques that allow you to take a short ConeBeam CT and still get great imaging. What's the most important is what is the minimal amount to give you the data you need to position your patient appropriately, right? So ConeBeam CT using kV energies is such a little aggregate dose to the patient. Claire kind of talked about what that looks like over the course of a patient treatment. I really don't feel that it's a major contributor to patient dose. Maybe the physicists on their call out for comment, but in a lot of cases we don't really look at that kV-CBCT as a risk. The risk is under treating or over treating.
Yeah, I totally agree with you, Jill. And for example, when we do stereocranial treatments, so we're treating multiple metastases in the brain, we even do a ConeBeam CT after treatment to make sure that the patient hasn't moved during treatment. So I think in most cases, more information is more power to you to make the right decisions. So I wouldn't be particularly worried about doing 3, 4, maybe even 5 cone beams daily, if that means you're treating as accurately as you possibly can. And again, it needs to be put into perspective of what their total dose is, what the risk is if you do have a geographic miss.
Thank you. Well, I know we're running over time and we don't have any more questions. So I just wanted to say thank you very much, Jill and Claire. It's been a pleasure. And it looks like there may be one last question that has come in. So if it's all right, I'll read that out. And then if there are any other questions from the audience, please feel free to email me and I can relay them to Claire and Jill. And so the question is, for my research work, how do I compare the prescribed dose?
I'm not quite sure what that question means. What are you comparing to? Sorry, maybe Jill, that makes some sense to you. I'm just not quite sure what that question means. I don't want to give wrong advice.
So I think it really depends on what Claire said. What are you comparing to? What type of imaging are you doing? I don't believe there is an ability to look at your kV dose without, like if you're able to keep track of that in an Excel spreadsheet or something like that, or run some type of report that pulls out all of the images done for the patient and then create your own Excel spreadsheet from there that creates dose. I know within, I believe it's Mosaic, when you take an MV image like a port film or a double exposure, you do have the ability to take that dose. So let's say you're doing 2 MUs out of whatever 200, you do have the ability to subtract that dose, or you used to be able to subtract that dose from your overall treatment field. So it doesn't, to Hanifa's point, it doesn't add to the dose, it actually subtracts from your daily dose or your max dose for the patient treatment. So it's not like you're prescribed to give 200, you take port films and you give 204, it's not going to flag you. You're actually going to give 196 for your treatment field. So, and that's really a clinical protocol decision whether you're going to do that or not. In a lot of cases, you don't bother, because it's really actually not a huge contributor to patient dose. It's a small percentage. So I think for KV, it's a different story, because we don't have that ability to add or subtract. That would have to be a manual process where you're pulling out the images or indicating what images have taken and then estimating the delivered dose based on some of the parameters that Claire showed in her presentation.
Yeah, look, I think particularly if you're looking at KV and ConeBeam CT doses, even if you do a dose calculation or take a measurement, the dose that you're going to be getting is like a whole body equivalent dose. So you can't really add that to a prescription because you're not comparing the same thing. So your imaging dose is calculated in a different way than your radiation therapy treatment dose. So it's a little bit more difficult. You can't just add the two together because they're actually calculated off different things.